Hello, my name is Stephen Kesten. I am the Chief Medical Officer for ATCOR Medical. I will be discussing non-invasive measurement of central aortic blood pressure and the role it can have in drug and medical device development. The objective of the presentation is to describe the rationale for integration of central aortic blood pressure monitoring into clinical drug and medical device development programs and how such integration can improve the efficiency and success of programs for hypertension and other vascular disorders. As you all are aware, drug development is a very expensive undertaking and one that is not necessarily associated with a high level of success. The study by Damasi and colleagues shows the total out-of-pocket and capitalized cost for development for each new drug approved. The total capitalized cost exceeds $2.5 billion. While continued development of new therapeutic options is clearly necessary for the ongoing improvement of health globally, the investment is high, and the likelihood of success is far from guaranteed. The recent publication by Wouters shows the probability of success from one development phase to FDA approval according to different therapeutic areas. Please note, for cardiovascular, even at phase 3, there's a 62% probability of success. A critical area is phase 2, where there is only a 20 to 35% likelihood of success. This is a simple graphic that shows where the decisions become most cost-effective. Early on in development, the investment is relatively modest, but the ability to change and adapt is high. Once phase 3 is reached, a company is fairly locked into a development pathway in terms of design and endpoints, and cost becomes exorbitantly high. However, I consider phase 2 as the influence sweet spot where you can have the largest overall impact on overall spend and risk. I will return to this concept later in the presentation. I would like to now provide some background on non-invasive measurement of central aortic blood pressure. Monitoring brachial blood pressure has been the basis for management of hypertension for decades. However, hypertension and vascular disorders continue to be substantial socioeconomic problems despite the availability of brachial BP monitoring and numerous therapeutic interventions. So why consider monitoring central aortic blood pressure? Central pressures are the pressures directly transmitted to vital organs, directly impact the organs, and are, in general, from various studies, more highly correlated with end organ damage and clinical outcomes compared to brachial BP. The technique that is used to capture central pressures non-invasively is referred to pulse wave analysis. Critical to this is the understanding that blood pressure is based on the forward pressure wave during systole combined with the pressure wave that is reflected back from the periphery at the various branching points. Pulse wave analysis transforms the data from the peripheral blood pressure waveforms into central pressure variables. Among the variables produced are central aortic systolic and diastolic pressure, pulse pressure, augmentation pressure, and augmentation index. Augmentation pressure is the contribution of the reflected wave to the forward wave during systole. The augmentation index is the augmentation pressure divided by the pulse pressure. These are important variables that reflect arterial stiffness. Currently, there is only one FDA-cleared medical device for the full assessment of pressure waveform analysis in adults, which is the ATCOR device. This is a dual arterial pressure monitoring system that measures brachial pressure and central aortic pressures in the same setting using the same device. Other variables such as subendocardial viability ratio are derived, but for brevity, I won't be describing the specifics in this presentation. It is important to recognize that brachial pressures and non-invasively obtained central pressures are not redundant. The figures in the slide illustrate the point. For example, patient 1, in red, has very similar brachial and central systolic pressures, while they are very different from patient 2, in blue. Although there is a high correlation between the pressures, They provide additional important information that can be used clinically and should be used as complementary. This slide outlines the various reasons why monitoring of central pressures should be part of clinical care and in drug development programs. Central pressures provide additional risk determination of vascular disease from hypertension that appears to be independent from brachial pressure. An example from publications showing that elevated central pressures early in pregnancy are associated with heightened risk of preeclampsia, even when corresponding brachial pressures are normal. Central pressures can also identify patients who may be at risk of being over or undertreated for hypertension disorders, which has implications for drug development. Elevated central pressures in multiple publications are associated with increased risk of end organ damage such as left ventricular hypertrophy, increased carotid intima medial thickness, and decreased glomerular filtration rate. Finally, several studies have noted that different classes of drugs can have differential effects on central and brachial pressures, which again has implications for drug development. I will now move on to specific situations that demonstrate the utility of incorporating central aortic blood pressure monitoring in drug and device development programs. It is absolutely critical to have an accurate baseline assessment of hypertension in a drug development program. Despite protocol-mandated BP procedures, there is still a real possibility of suboptimal implementation and measurement. Having another measure, such as central aortic pressures, provides corroboration that the brachial baseline is likely a true baseline. For example, if you have a patient with minimal to borderline stage 2 hypertension but normal or even low central pressures, this subject may not be a suitable candidate and may indeed be indicating the possibility of white coat hypertension. On the other hand, if there is clear evidence of elevation of brachial and central pressures, you can be much more confident about the subject meeting the intention of the inclusion-exclusion criteria. I referred to white coat hypertension in the previous slide. White coat hypertension occurs in approximately 20% of office patients. Consider the implications if 20% of the critical blood pressure data in a cardiovascular trial is not identifying patients correctly. These issues also apply to follow-up values that are key to the evaluation of efficacy and safety. When considered a priori, discrepancies between central and brachial pressures baseline and at follow-up can be examined through pre-specification in a statistical analysis plan. Non-invasively obtained central blood pressure variables can be used as endpoints for therapeutic effect. I'm not suggesting that these variables should be used as primary endpoints unless there have been extensive discussions with regulatory agencies. However, variables such as central aortic systolic pressure can be used as secondary endpoints. Peer-reviewed publications support threshold values for central systolic pressures that can be used much like brachial BP thresholds for hypertension guidelines. The information from central blood pressure in clinical development programs may identify patients at risk of adverse effects or efficacy outcomes. While this can lead to implications for prescribing information, it may also identify cohorts of patients most likely to have positive or negative effects, which is important and may actually assist in gaining regulatory approval. Phase 2 trials are about narrowing the program to find the right dose for the right population. Suboptimal decisions in Phase 2 have profound and expensive downstream consequences. Often Phase 2 trials do not have the statistical power to distinguish between various dosing arms in the trials. In addition, surrogate endpoints are often used that are different from the primary endpoint anticipated for the pivotal Phase 3 program. It is essential to have as much clinically relevant information in order to determine what dose and dose frequency will be taken into Phase 3. Central blood pressure variables allow for additional information about therapeutic effect when the effect size is imprecise, whether different therapeutic effects are being observed than what was originally anticipated, and evaluating signals for anticipated or unanticipated adverse events. For example, certain populations, such as the elderly, may be at higher risk for hypotension. To summarize, the additional information allows for more informed decision-making for continuing with the program, terminating a program, or deciding whether additional phase 2 data is needed. Data from central blood pressure variables allows for additional information about safety. Signals from brachial blood pressure or from imbalances in adverse events can be supplemented with information from central blood pressure variables. Examples are described in the slide. Vulnerable populations, that is, populations predisposed to clinically relevant adverse events, may be identified prior to the adverse events through monitoring of central blood pressure. Even within a phase 3 program, due to the relative infrequency of certain adverse events, the signals are imprecise. Evaluation can benefit from additional information that central pressure supply that might either reassure or alert a clinical development team. Information of central blood pressure is related to peripheral blood pressure, and as such, it is possible that such information could find its way into prescribing information. Indeed, the FDA encourages companies to identify population characteristics and responses to intervention that will lead to an improved benefit-risk information for a drug. The information can also provide competitive advantages to companies who have not examined such variables in their programs. For programs targeting hypertension and other cardiovascular diseases, central blood pressure is related physiologically to key endpoints of the program. Provided that the program has reached its primary endpoint and is approved by the FDA, related physiological information could be included in external communications such as peer-reviewed publications and company-sponsored programs, which again can potentially provide competitive advantages. In summary, variables from pulse wave analysis should be considered in development programs for the following reasons: confirmation of hypertension at baseline and reliability of the baseline value, confirmation of blood pressure at follow-up, additional endpoints for evaluation of therapeutic effect, informing dose selection during the phase 2 dose ranging studies, avoiding misleading information due to white coat hypertension, improved patient selection and benefit risk evaluation, provision of supporting information that may enhance the likelihood of regulatory approval, potential incorporation to prescribing information, and increased opportunities for post-approval communication. I would now like to briefly expand on some of the operational details on how remote patient monitoring and decentralized clinical trials can be enhanced using devices that non-invasively measure central aortic blood pressure. As everyone is aware, the emphasis of decentralized clinical trials has accelerated since the COVID pandemic. A pragmatic definition is listed here by Van Norman from the Journal of the American College of Cardiology published last year. The Sphygmo-Core XL system has been essentially the gold standard for non-invasive measurement of central pressures for many years. The system has been used in clinical trials involving major pharmaceutical companies and academic centers. Thousands of units have been used for research purpose and many used for clinical practice. The picture on the left shows the Sphygmo-Core XL system, which measures both brachial and central pressures. The central figure represents the pulse device, which will be introduced this year. It is a home dual blood pressure monitor, that is to say, it is cuff-based and measures brachial and central aortic pressures. In addition, the pulse device measures multiple other clinically relevant arterial features and variables. It has been designed to be used clinically and for clinical trials. On the far right is the CONNEQT Band. The CONNEQT band is worn on the wrist and includes ambulatory dual blood pressure monitoring using a side sensor, as well as a variety of other health-related variables. The CONNEQT band has a full suite of measurement capabilities with a focus on arterial vascular variables. The patented PPG side sensor technology enables numerous other high-fidelity arterial health features to be obtained in an ambulatory and nocturnal environment, including brachial and central blood pressure. The sensor is activated by placing a finger on the sensor. As with the other medical devices I referred to, it will connect with the proprietary app and a cloud-based system that can be incorporated into clinical trials. Next year, we'll be introducing a clinic-based version of the Pulse, which has upgraded features and technology. This is anticipated to be an attractive approach for small and large clinical trials for hypertension, related disorders, and other cardiovascular diseases. The entire system will be cloud-based. The Pulse home device, clinic device, and CONNEQT band are integrated into the cloud-based system. The integration and data handling will meet all the FDA requirements for HIPAA and cybersecurity. This is purposely designed as a complete remote ecosystem for enabling decentralized clinical trials. ATCOR Medical offers an entire suite of clinical trial services to allow for incorporation of centralized monitoring for brachial and central aortic blood pressure. The list of services is described in this slide. Full support includes overreads, quality control, report generation, data transfers, etc. All of the office and home-based equipment will be managed through these central services. While not part of this presentation, ATCOR Medical also offers tools for measurement of pulse wave velocity for those who are interested in assessing arterial stiffness. ATCOR has a long history in pulse wave analysis and involvement in clinical trials. To date, 46 clinical trials from 16 different companies have incorporated ATCOR technology and clinical trial services in a variety of indications, which are listed at the bottom of the chart. I would like to step back and use several analogies to illustrate incorporation of central pressures as part of a broader context. Consider that decades earlier, we had for diabetes, urinary dipsticks for glucose, and fasting blood glucose. Now, no one would manage diabetes without the addition of a hemoglobin A1C. Electrocardiograms were the sole basis of office assessment of heart rate, rhythm, and general left ventricular function. However, now for many decades, echocardiograms are core evaluations and routine. Both are used and neither replaces each other. For decades, COPD guidelines were only based on spirometry. However, in 2017, the GOLD COPD guidelines added COPD exacerbations for maintenance therapy management decisions. We now use two-factor identification or deadbolt locks in addition to regular latches and locks. Brachial peripheral blood pressure will continue to be the mainstay for evaluation of blood pressure and management decisions. But now we have another tool, and both of these should be considered as part of the management of vascular health. This slide summarizes the various categories to which pulse wave analysis can be used to help improve the efficiency and probability of success in both drug and device development that are targeting vascular diseases. In conclusion, I hope I have been able to outline the rationale for incorporating non-invasively obtained central aortic blood pressure measurement and monitoring into clinical trials for products targeting cardiovascular disease. As well, I have provided rationale and examples of how incorporation of dual blood pressure monitoring can improve key decisions during drug and device development and increase the likelihood of both regulatory and commercial success. Based on current technology, the rationale outlined today, and the availability of non-invasive dual arterial pressure monitoring systems, these Dual arterial BP devices should be considered for drug and medical device development for hypertension and other cardiovascular diseases. If you are interested in using such monitoring in your development program or clinical trials, or are interested in partnering opportunities, please contact ATCOR Medical. Thank you for your attention today.